Controlling. The third essential variable is controlling. Controlling is defined as the mechanisms on how a ventilator controls gas delivery during inspiration. There are only two primary controlling types: volume controlling and pressure controlling. At any given time, a ventilator can only control either the volume or the pressure, but not both. In addition, there are two extended controlling mechanisms. Pressure controlling has a variant called adaptive controlling. Some ventilators have hybrid controlling. We will explain them one by one. Volume controlling or flow controlling. A better term for volume controlling is flow controlling, because during inspiration a ventilator actually controls the flow of inspiratory gas delivered into the circuit. At the end of inspiration, the set tidal volume is delivered. Volume controlling is shaped with three primary controls: VT, TI and peak flow. Typically, we set either VT and TI or VT and peak flow. The ventilator calculates the third one automatically. Volume controlling may have a secondary control: inspiratory, flow pattern. Square flow pattern is the most common one. Some ventilator provides only square flow pattern for volume breaths. However, some other ventilators provide more flow patterns. For example, Hamilton G5, S1 and C6 ventilators provide square, descending, and sine flow patterns. The major perceived advantage of volume controlling is stable tidal volume as well as minute volume, with which we may feel comfortable. However, volume controlling has four inherent disadvantages. With volume controlling, a ventilator dictates all important aspects of inspiratory gas delivery. This is hardly acceptable if the patient is active. This explains why patient ventilator asynchrony often occurs in volume modes. With volume controlling, the tidal volume that a ventilated patient receives is always less than that a ventilator delivers into the circuit. This is due to gas compression in an elastic breathing circuit. The tidal volume difference is invisible volume loss. For instance, if the set tidal volume is 500 milliliters, the patient may only get 450 milliliters. This invisible volume loss needs to be corrected by circuit compliance compensation. With volume controlling, leak compensation is impossible because a ventilator delivers exactly the set volume into the circuit. With volume controlling, the peak pressure is variable, dependent on the set VT, peak flow, the patient's respiratory resistance and compliance, and breathing efforts. A constantly high peak pressure can damage the lungs. Due to these disadvantages, volume controlling has given place slowly but steadily to pressure controlling. Pressure controlling. With pressure controlling, a ventilator first draws a target airway pressure profile according to the settings of TI and inspiratory pressure. During inspiration, the ventilator dynamically adjusts the inspiratory gas flow to minimize the gap between the actual airway pressure and the target pressure profile. This means, the ventilator increases the inspiratory flow, if the monitored pressure is much below the target pressure. It decreases the inspiratory flow, if the monitored pressure is a bit below the target pressure. It stops the inspiratory flow if the monitored pressure matches the target pressure. Pressure controlling is shaped with two primary controls, TI and inspiratory pressure. Inspiratory pressure refers to the intended positive pressure applied above PEEP. It drives gas to move into the lungs. In Hamilton medical ventilators, inspiratory pressure is labeled either as pressure control for mandatory breaths, or as pressure support for spontaneous breath. Pressure controlling may have a secondary control, pressure ramp, P ramp, or rise time. It is defined as the time required for airway pressure to rise to a target pressure at the beginning of inspiration. A short P ramp means a fast circuit pressurization, and vice versa. If volume controlling is compared to a dictator, Pressure controlling is somewhat illiberal because VT and inspiratory flow can vary per the patient's demand. Because of this important property, patient ventilator asynchrony occurs much less frequently. When the system has a leak, causing circuit pressure to drop, the ventilator immediately responds with increase in the inspiratory flow. This is how leak compensation works. With pressure controlling, a ventilator can effectively compensate a moderate leak. With pressure controlling, the tidal volume is variable, dependent on the set inspiratory pressure, the patient's respiratory resistance and compliance, and the patient's breathing efforts. Under unfavorable conditions, the resultant tidal volume can be too large or too small. It is important to set tidal volume alarms properly to safeguard the patient. Adaptive controlling. Adaptive controlling represents the outcome of the efforts to exploit the advantages and to minimize the disadvantages of both volume and pressure controlling. Adaptive controlling is a variant of pressure controlling. With pressure controlling, the inspiratory pressure is set, the peak pressure stays stable, and the resultant VT may vary. With adaptive controlling, the inspiratory pressure is automatically regulated breath by breath to match the monitoring VT to the target VT set by the operator. In detail, the ventilator does the following. Increases inspiratory pressure if the monitored VT is below the target. Decreases inspiratory pressure if the monitored VT is above the target. Keeps inspiratory pressure unchanged if the both tidal volume are equal. Adaptive controlling may be misperceived as volume controlling because tidal volume can be set in both cases. Other than that, they have nothing in common. Here the waveforms of volume, pressure and adaptive breaths exhibit the similarities and differences. The major advantages of adaptive controlling are: A. The actual VT can be rather stable, especially in passive patients, and B. It keeps most advantages of pressure controlling. For optimal performance, adaptive controlling has a hard, yet rarely mentioned requirement for the operator. The target volume must be always adapted to the patient's current ventilatory demand, which may change over time. An unfavorable scenario is that the target volume is set lower than the current demand. The patient has to breathe harder to satisfy the demand. As the monitored VT exceeds the set target, the ventilator reduces the inspiratory pressure. At the end, the patient does all work of breathing, and the ventilator does little. Hybrid controlling. Hybrid controlling is defined as application of both pressure controlling and volume controlling within the same mechanical breath. In Chet-Burns' taxonomy of mechanical ventilation, hybrid controlling is named as dual control. Typical examples include volume-assured pressure support, VAPS, mode of Bird 8400 STI ventilator and volume control mode of Maquet ventilators. We will not go deeper with hybrid controlling because it is complicated to understand and has not been popularized thus far.